Now let's talk about the rehabilitation phase. This phase actually begins the moment the injury occurs and can last for years. It's not something that starts at discharge. Rehabilitation is woven into every stage of burn care. The goal is to help the patient regain function, adapt to new realities, and reintegrate into their community. The rehabilitation phase is demanding both physically and psychologically. Patients may face intense distress, and some develop psychiatric conditions, especially if the burn was caused by trauma, like house fires, explosions, or accidents with fatalities. Depression, anxiety, post-traumatic stress disorder, and sleep disturbances are all common. Early consultation with mental health professionals is essential. Nurses need to recognize that emotional healing is just as critical as wound healing. Let's review some of the common complications in rehabilitation. Patients may develop neuropathies due to nerve compression or damage. These require thorough neurovascular checks and referral to therapy. Wound breakdown can occur if new skin is fragile and stressed by movement or friction. Hypertrophic scarring and contractures are major concerns. Without proper positioning, splinting, and exercise, joints can lose range of motion permanently. Contractures may even require surgical release. Joint instability and chronic pain are other challenges. Nurses need to monitor for these complications daily, work with the therapy team, and educate patients on protective strategies. Scar management is a huge part of this phase. Normal scars mature flat and pale, but burn scars often become hypertrophic, raised, red, hard, and itchy. Some patients develop keloids, which extend beyond the original wound and can be nodular and rope-like. Prevention and management require a combination of therapies. Pressure garments are the gold standard, custom-made elastic clothing worn 23 hours a day for up to 2 years. Silicone inserts, scar massage, and early splinting all help control tissue growth. Nurses must explain to patients why these measures matter, because compliance is not easy. It's hot, uncomfortable, and socially awkward to wear compression garments, but the outcome depends on it. Now let's consider the psychosocial aspects. Survivors worry about disfigurement, disability, independence, jobs, family responsibilities, and intimacy. Social stigma is real. People with visible scars may face prejudice in employment, social interactions, and even daily encounters with strangers. Nurses need to validate these concerns, provide resources, and connect patients with support systems. Organizations like the Phoenix Society for Burn Survivors are invaluable. They provide peer counseling, education, camps, and even workshops on topics like makeup application to help survivors feel more confident. Community reintegration is also part of rehabilitation. Discharge planning begins early. Nurses must ensure the patient and family understand wound care, dressing changes, splint use, pressure garment application, nutrition, and pain management. Written instructions and demonstrations are essential. Transitional care may include outpatient therapy several times per week, or even inpatient rehab stays before home discharge. Nurses assess whether the home environment is safe and supportive, and whether caregivers are capable of providing the necessary care. Now let's shift into abnormal wound healing. Remember, normal scars become flat, pale, and soft. Abnormal scars include hypertrophic scars, which stay within the original wound boundary, and keloids, which extend beyond it. Risk factors include darker skin pigmentation, younger age, and genetic predisposition. Prevention starts early with pressure therapy, silicone sheets, and scar massage. Nurses reinforce occupational therapy recommendations and help patients adhere to sometimes frustrating regimens. Reconstructive surgery may be needed once scars mature, usually after a year. Setting realistic expectations is critical. Surgery can improve function and appearance, but scars will never disappear completely. Now let's pull it all together with the nursing process during the rehabilitation phase. Assessment begins broadly. Nurses gather information about the patient's education, occupation, leisure activities, cultural background, religion, and family dynamics. Self-concept, coping style, previous hospitalizations, and mental status are explored. Ongoing physical assessments include range of motion, ADL function, signs of neuropathy, activity tolerance, and the condition of healing skin. Nurses document participation in self-care because this is a key marker of progress. Based on this, common nursing diagnoses include activity intolerance due to pain and immobility, disturbed body image due to altered appearance, impaired mobility from contractures or scarring, and knowledge deficit about home care. A potential collaborative problem is inadequate psychological adaptation. Some patients may not cope well without professional help. Planning goals are clear. Increase mobility and ADL participation, adapt to body image changes, build understanding of treatment and follow-up, and prevent complications. Interventions focus first on promoting activity tolerance. Rehabilitation is painful and exhausting, but consistent PT and OT exercises prevent muscle wasting and maintain function. Activity is gradually increased, with fatigue and pain carefully monitored. Diversions like family visits or recreational therapy can improve motivation. Nurses schedule care to protect rest periods, especially after dressing changes when analgesics are most effective. Insomnia and nightmares are common, so reassurance and sleep aids may be used. Conserving energy by controlling pain, preventing chills, and supporting wound healing is also critical. Next, nurses work on improving body image and self-concept. Survivors often express deep fears. Will I be disfigured? Will I ever work again? What about intimacy? Nurses provide space for these concerns, reinforce strengths, and challenge societal prejudice by encouraging patients to re-enter social roles and relationships. Connecting them with peers who have survived burns can be powerful. Promoting physical mobility is constant. With aggressive PT and OT, most patients can avoid contractures and severe scarring. Nurses encourage compliance, monitor for complications, and coordinate surgical interventions if full range of motion isn't restored. Managing complications requires vigilance. Some patients with limited coping skills or psychiatric histories may not adapt well psychologically. Nurses identify these patients early and arrange counseling or psychiatric referral. Finally, we focus on home and community-based care. Education is key. Patients and families must demonstrate dressing changes, wound care, splint application, and use of pressure garments before discharge. Nurses provide written instructions and reinforce them frequently. Coordination with burn centers ensures ongoing evaluation and adjustment of care. Outpatient PT and OT may be required several times weekly. Nurses monitor adherence, support caregivers, and provide referrals as needed. Transitional care may be required for patients who cannot safely return home immediately. Evaluation of outcomes looks at 5 main areas. 1. Does the patient demonstrate adequate activity tolerance with energy for daily life and adequate sleep? 2. Has the patient adapted to altered body image and resumed social roles? 3. Does the patient have mobility sufficient for ADLs and absence of contracture complications? 4. Does the patient understand and perform required self-care and follow-up? And 5. Has the patient avoided complications, including psychological maladaptation? If we can check those boxes, we've done our job. Rehabilitation is not just about survival, it's about restoring dignity, independence, and quality of life. So to wrap this up, burn care is a marathon, not a sprint. From airway management and fluid resuscitation in the first hours, to wound healing, infection control, mobility, and finally reintegration into society, the nurse is present at every step. You will be the advocate, the educator, the motivator, and sometimes the one person who refuses to let the patient give up. That's what makes burn nursing so challenging and so profoundly rewarding.